Start recording. Okay, so we are going to be doing a bit about anemia today, guys. So we'll try and rattle through the presentation relatively quickly. There's a lot to get through. Anemia is quite a big topic. Once we've done that, we're going to have some MCQs to go through just to cover some key areas and hopefully demonstrate a little bit what we're going to be going through. Whilst we're just need to share my screen properly. Once we've gone through the presentation, illustrate some topics, we'll go through some multiple choice questions and just recover some knowledge, some of the key stuff that I think that you guys should know a little bit more about. If you've got any questions, please just stick them in the chat and I will make sure that I try and answer anything that you want to know a little bit more about as we go through. So these are our objectives for the day. We'll make a start. So starting off with the definition of anemia. Very basically, anemia is a reduced level of hemoglobin. 2 standard deviations below the mean. Each hospital has its own lab values, so it will vary from where you work. For your exams, you should be given a standardized set, so you won't be asked to know them off the top of your head. You should just be told what the values are for that particular exam that you're sitting. The WHO defines them as these levels for different categories, so varying between pregnant women, children, premenopausal women, and men and postmenopausal women. But it's going to begin to you for the time of your exam, so just have a vague awareness of roughly what those levels might be. Clinical relevance. So anemia is the most common disorder that you'll see in practice. Lots of people in hospital and in the community will be anemic. It can make people very unwell, and it often goes as the presenting sign of something a bit more serious. So when you see it, it's not something to be ignored. You need to try and find out what the underlying cause is, and we're going to go through a lot of those underlying causes in some detail. We'll cover the most important ones in detail, and then we'll mention briefly a lot of the other underlying reasons for people having an anemia. So the pathophysiology, basically we have this lineage of blood cells. There can be problems anywhere along that lineage that result in erythrocytes, so your red blood cells. A problem somewhere along that production line can result in anemia, and red blood cells are supposed to last 128 days on average. If something is destroying red blood cells, then you will also get an anemia. So it's either down to a problem with production and you're not producing enough, or a problem with destruction and you're losing too many. So this is just a quick recap of the lineage of blood cells. So you've got your multipotent stem cell, and in the myeloid lineage, you will find your erythrocytes or your red blood cells. This is going to be something to just have a quick glance over and bear in mind. So these are your lymphoid cells and your myeloblast lineage. Those are your white blood cells. That's going to be important later on for thinking about leukopenia and leukocytosis. We're going to be talking a little bit about leukemias and hematological malignancy. That'll be covered in more detail, I'm sure, in a future session, but I am going to mention it briefly today. And of course, you've got platelets as well, thrombocytes, which also come from the myeloid lineage. This is your innate immune system, these white cells, and this is your adaptive immune system. And that's all I'm going to talk about today in terms of that. We will mention a few extra bits later on in a different context, but this is just so you can remember that erythrocytes come down this path when they're made. So, some of the underlying causes of anemia, there are loads and loads of things that cause anemia. And there are lots of different reasons why your hemoglobin count might drop below the normal range. We're going to talk about some of these in a bit more detail. There's a few big ones, a few of the more common causes of anemia we'll talk about in more detail. But this is just to give you an idea of the scope of things. If you see a low HB on a full blood count, which you will see a lot, there is a huge range of things it could be. So we need a way of trying to whittle down quickly what it is that might be causing it. We don't want to investigate everybody for everything. So it will be helpful for us to have a way of quickly narrowing down what might be causing that anemia. So we want a classification system, something to make that job a bit more easy. In the full blood count, this is a selection of the things that will come up on a full blood count, hemoglobin level, which is what defines an anemia. We've also got the hematocrit, which is the volume, the percentage of red blood cells in whole blood. We've got the red cell count, which is just a raw number of red cells on counting in a sample of blood. You've got the mean corpuscular volume, and this is the way that we categorize anemia because it's down to the size of the cells. Different causes of anemia produce different size red blood cells, and it's the quickest way for us to categorize. And then just very briefly, you've got the average amount of hemoglobin per cell, which is the mean corpuscular hemoglobin. We've got the mean corpuscular hemoglobin concentration, which is the average amount of the red blood cell that is taken up by hemoglobin. We've got the red cell distribution width, which is an idea of from the smallest to the biggest red cell, how closely are they grouped? This is the normal range. If you've got a big variation, so lots of small cells and lots of big cells, this distribution width is going to be wider. And then you've got your white blood cells, of course, which is your immune cells, and your platelets, which are used for clotting. Both of these can change for different reasons, as I'm sure you know. So we said that MCV is going to be the way that we quickly identify what's causing an anemia. So with a microcytic anemia, there's a handy acronym that you can use to remember some of the biggest causes of a microcytic anemia. And as we said, that MCV, 80 to 100 femtoliters is the unit. So 80 to 100 femtoliters. If it's less than 80 femtoliters in size, so you've got little red blood cells, the acronym that we use is TAILS, and that stands for thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. Now, this iron deficiency anemia is the most common cause of anemia in the UK. So this is going to be a really important one for us to know about, and we'll tell you more about this as we go on. Thalassemia is also very common, as is anemia of chronic disease. Lead poisoning and sideroblastic anemia are much more rare, so we're not really going to mention them today, but they can cause a microcytic anemia. We'll talk a bit more about all of these three. The next classification of anemia makes sense, going on size. Normocytics are normal size red blood cells. So you've got a normal size red blood cell, and you've got reduced HB. And the acronym that we can use to remember causes of normocytic anemia is ABRA. So we've got anemia of chronic disease, and I'll talk a little bit about why it appears in both normocytic and microcytic. Bone marrow failure can cause normocytic, renal failure, and acute hemorrhage can also do it as well. And then finally, the last category is a macrocytic anemia. So this is for big red blood cells, and the acronym that we can use is bald hair is the one that I've come across. So you've got B12 and folate deficiency, which is a really, really common cause of a macrocytic anemia. Alcohol, liver disease, lots of different drugs, and we'll touch on some of those later on. Hypothyroidism, aplastic anemia, and myelodysplasia, so things that infiltrate the bone marrow, and reticulocytosis, increased reticulocytosis, INR, which is a little bit of a fiddle for this acronym. But these all sum up causes of big red blood cells. Reticulocytes are your, as it was mentioned in my notes from one of the earlier slides, these are your immature red blood cells that are released into the circulation that then quickly mature into erythrocytes. And the production of reticulocytes can signal that your bone marrow is trying to pump out more red blood cells as a reaction to bleeding or other causes of reductions in your red cell count. So it can be a reaction to bleeding. The way that we can split macrocytic anemia, so there's megaloblastic and non-megaloblastic, and I'll talk a little bit more about exactly what that means, but basically what you need to remember is that these are the causes of megaloblastic anemia. So B12 and folate deficiency cause a megaloblastic anemia with big red blood cells, and all of these other causes cause a non-megaloblastic macrocytic anemia. We'll talk about what megaloblasts are and how you can recognize a megaloblastic anemia. So the symptoms of anemia: tiredness, shortness of breath, headaches, dizziness, palpitations, and they can make things, conditions like these worse. Now, the reason for that is because all of these symptoms come down to the fact that your red blood cells and your hemoglobin molecule carries oxygen around the body. If you don't have enough hemoglobin, your tissues are going to struggle to get the amount of oxygen that they need. So you need oxygen to function. For aerobic activity, oxygen is obviously vital. So that tiredness, that shortness of breath, that's going to come from your body working harder to try and get the same result. Dizziness, palpitations, like you're actually going to be having signs of tachycardia and tachypnea as your body works harder to increase cardiac output in order to try and get the same level of oxygenation to the tissues. Here is an illustration of conjunctival pallor, which is a sign of anemia that's common to all kinds of anemia. We're going to take a little look in a second at some signs of some specific types of anemia, and what I want you to do is tell me what the sign is and what kind or kinds of anemia it could be suggesting. So I want a little bit of interactivity, if you don't mind. So can anybody just message in the chat and tell me what that is and what it might be a sign of? Anybody know what that is? So nail sign for anemia, so it's spooning of the nails. What you're looking at there is spooning of the nails. Does anybody know what that sign might mean? What is also known as? So that's koilonychia, which is a sign of iron deficiency. So if you're doing your cardio exam in your OSCEs and you see somebody with spooning of the nails, that's what koilonychia looks like, and that can be a sign of iron deficiency anemia. Does anybody know what this is? So that's the corner of the mouth. It's looking dry and cracked and irritated. Does anybody know the name of that sign and what it might be suggestive of? Okay, so that's angular cheilitis or angular stomatitis, it's also known as. And that can be a sign again of iron deficiency and B12 deficiency. So if you're doing your cardio exam and you get somebody to open their mouth, what you can do is really signpost in your OSCEs and have a really good look in and make sure that you're looking at the corner of the mouth and you're, I don't know if Manchester, they like you to announce what you're doing, but you could certainly say when you get to looking at the face that I'm looking for signs of angular cheilitis or angular stomatitis. And you'll look very clever if you do that. And does anybody know what this sign is, what it's suggestive of? So we've got an inflamed tongue, it's looking red, it's looking very smooth, you can't make out the papillae very clearly on the tongue there. It looks irritated and sore. It's atrophic glossitis, which is again iron deficiency and B12 deficiency. And finally, this sign hopefully should be pretty easy to spot. Can anybody tell me what? So he's got yellowing of his eyes. It's clearly jaundiced. What kinds of anemia would you expect to see that in? There's loads of different ones. The broad category that come under, so Haemolytic anemias cause jaundice. When you get breakdown of your red cells, it frees up bilirubin that is stored within the red blood cells, and that unconjugated bilirubin builds up and causes jaundice. So we've done a little bit of a run through of how anemia is classified, what are some of the numbers involved. We've talked about microcytic, normocytic, and macrocytic anemias. We'll talk a little bit more about megaloblastic anemias in a little bit. We're going to go through and look at some specific causes now. Some we'll mention in more detail than others. So the big ones that I'm thinking of are iron deficiency anemias, B12 and folate, because they don't tend to come up in other areas. We'll also touch on a lot of the other things that cause anemia, but a lot more briefly. Does anybody have any questions at this point before I move on? Okay, right, we'll make a start with these then. So, with iron deficiency anemia, so it's the most common cause of anemia worldwide. It's more common in women than it is in men. And serum ferritin, so serum ferritin is the best way to measure it in the blood. So serum ferritin is something that's quite unreliable because it's also an acute phase protein. So if you measure a low serum ferritin level as less than 15 micrograms per litre, you've confirmed that the reason for your microcytic anemia is iron deficiency. However, people can be iron deficient and have a raised ferritin because ferritin goes up in response to infection, inflammation, all that kind of thing. So seeing a high ferritin doesn't necessarily mean that they're not iron deficient. If you see a low one, less than 15, you've confirmed the diagnosis. So you just need to be wary in people that you're suspecting of iron deficiency anemia who also have symptoms of infection or inflammation. Your iron studies is not going to necessarily be the best test. It's not going to be the most informative, and you might need to base it on clinical suspicion rather than anything else. The reason that iron deficient leads to anemia, so iron is used in forming the heme molecule. Most of your body's total iron stores are in circulating blood. So 2/3 of the iron in your body is in your circulation, in your red blood cells. If you start losing red blood cells because you're bleeding, be that acutely or chronically, you're going to start becoming iron deficient quite quickly. If you're not able to produce effective hemoglobin molecules, then you're going to produce small red blood cells. regards to the 2-week wait referral that's mentioned there, being 60 plus and having an iron deficiency anemia, so that's a 2-week wait referral, and somebody needs to be investigated with an upper and lower GI endoscopy. That's for anybody that's 60 plus. If you've got a man and they've got a hemoglobin level of less than 110, doesn't matter what their age is, they should also go for a 2-week wait upper and lower GI endoscopy, because in pre-menopausal women, they often run with a low hemoglobin because of their regular periods. They regularly lose blood, and their hemoglobin level tends to be lower than a man's. If you see a guy who's younger than 60, HB is less than 110, and he has an iron deficiency anemia, you need to send him for a 2-week wait referral. And then obviously, as women come into that postmenopausal bracket, if they have an iron deficiency anemia, they also need to be considered for upper and lower GI endoscopy on a 2-week wait. If you've done tests that have ruled out, so if you've done those 2-week wait referrals and they've had their endoscopy and you've determined that there isn't a significant mass or anything that needs to be referred on further, and it seems to be a case of simple iron deficiency anemia without a sinister cause, then you can give iron replacement therapy. And of course, if somebody is a young woman but still menstruating, and it's a case of iron deficiency anemia, then you can also start iron replacement therapy. And that treatment is typically 200 milligrams of ferrous sulfate 3 times a day for replacement. There are a few things that iron replacement therapy can do. So it can make people feel quite nauseous. It can cause constipation. It can cause diarrhea. Tips to make people better tolerate it are, you say to them they should take their tablets with food, either with or just after a meal, because it makes them better tolerate it. They tend to have less of a GI upset if they have it with food. They can break apart the capsules that they come in and sprinkle it on food so it comes as less of a bolus. That tends to reduce the constipating effect that iron can have. And you can also get modified release preparations, which aren't absorbed as well, but are better tolerated than your standard 3 times a day ferrous sulfate preparations. So if you were going to see somebody for an OSCE and you're going to have an explainer station and you're going to start them on iron therapy, what you should explain is, this is how you take it, these are some of the side effects you might have, and these are some of the things that we recommend in order to reduce those possible harmful effects. Because if you're seeing somebody in a consultation about iron therapy, they need to be on it for quite a while. So need to be on that replacement until their level is back to normal, and for a further 3 months, because their iron stores will be depleted. You need to replenish them, and that takes longer than just getting the measured HB back up to normal. Somebody described it to me once as, when you're iron deficiency anemic, you've got no food on the table and your cupboards are bare. If you replace their HB, you're putting food on the table, but you haven't filled up the cupboards. So you carry on for another 3 months in order to fill the cupboards up too. Does that all make sense? Just please message me if you've got any questions about any of that. So there are some specific symptoms of iron deficiency anemia, which I'll just mention briefly. Besides all those generic things, which are common to all types of anemia, these ones can be more associated with iron deficiency. So pica is an appetite for unusual items. So things like clay and dirt and like paint chips and things like that. That's pretty specific for iron deficiency. Pagophagia is a specific type of pica that is even more specific for iron deficiency anemia, and it's the appetite for ice. If people are eating ice and feeling a bit run down, think iron deficiency anemia. Pagophagia resolves really quickly. So if you start treating people with iron replacement, they will very quickly stop having this craving for ice. Beeturia is if you eat beetroot, you pee red. And the reason for that is because the beetroot is the colouring agent in beetroot is neutralised by ferric ions. So it would normally decolorise that red pigment. If you're iron deficient, you don't have those ferric ions in your bloodstream. And as a result, those ions retain their colour. And when you pee them out, you're peeing out this bright red wee. So that can be a symptom as well of iron deficiency. And restless leg syndrome, which is caused by other things as well. But if somebody's coming with the symptoms of anemia and also has restless leg syndrome, think along the lines of iron deficiency. So, B12 deficiency. B12 is another big cause of anemia in the UK. Causes a macrocytic megaloblastic anemia, as we mentioned. And it's an essential cofactor in DNA synthesis. So we'll talk about, when I show you a blood film later on, we'll talk about what effect that produces when you don't have B12. People that are at risk, so vegetarians and vegans can be more at risk because they don't tend to have the same amount of animal products in their diet. They need to make a concerted effort to try and find other sources of B12 that most meat eaters will get quite readily from eating animal products. Deficiency of B12 can cause neurological problems, and those are the kind of things that are sort of reduce your intake of B12. Pernicious anemia is the most common cause of B12 deficiency in the UK. So it's an autoimmune condition, and I'm sure you heard about it from your preclinical studies or your early years at uni. But what you have is there's an autoimmune attack of the parietal cells in the stomach. Those parietal cells would normally release intrinsic factor, which is just a protein that binds to B12 in the stomach, takes it down to the terminal ileum, and helps it get absorbed. Without intrinsic factor, B12 isn't really absorbed by the body. If you develop pernicious anemia, you start attacking your own parietal cells. When you attack those parietal cells, you don't release intrinsic factor, which means B12 doesn't get bound up and it doesn't get absorbed in the terminal ileum. So, by that logic, so pernicious anemia is quite common, and by that same logic, anything that disrupts either the release of intrinsic factor or absorption in the terminal ileum could also reduce the intake of B12. So if you've got GI surgery, so if you've had a gastrectomy and you've reduced the surface area of your stomach, or you've got atrophic gastritis and you've got inflammation and damage to the stomach lining, those are going to reduce the number of parietal cells and you're going to reduce your output of intrinsic factor. With diseases like Crohn's or celiac or small bowel bacterial overgrowth, you are affecting the terminal ileum and affecting the surface area you've got of, you're affecting your ability to resorb these bound B12 intrinsic factor complexes. Intrinsic factor is being produced in the stomach because that's okay and it's getting bound up, but because you've got damage further down the line, you're not being able to absorb it, and that can lead to B12 deficiency. Does that all make sense, guys? Yeah? Any questions at any point, please do just stop me. With folate deficiency, it often goes hand in hand with B12. They're often thought of as two sides of the same coin. Also really important for DNA synthesis. Also comes from dietary sources. Lots of animal products have folate in them, but also it's your leafy greens, your citrus fruits. Again, it comes down to inadequate intake, inadequate absorption, or increased folate use. These are some of the conditions that mean that you consume more folate. You can replace folate with tablets. B12 is typically done as injections. So if you see that somebody has a megaloblastic anemia, they've got a raised MCV, what you would typically do is check the full blood count, see the MCV is high and the hemoglobin's low, and then you do a B12 and a folate check. Often you'll see that they're both low together, and if they are, you need to replace B12 before you replace the folate, because when you replace folate, people often feel better right away. Like, it's a really dramatic effect with replacing folate. So you give somebody a dose of folate tablets, very quickly they will feel better, and you may ignore that B12 deficiency. That B12 deficiency can then go on to cause serious neurological problems, as we've mentioned. So if B12 and folate exist together, replace B12 first, and that's done with injections of hydroxycobalamin, which is done every other day for 2 weeks, and then you start to do them every 3rd month after that, I think it is. With folate, it's just a simple case of a daily tablet that will quickly replenish. Tend to check at 2 weeks to see if things are improving, and at 8 weeks just to make sure that they've resolved. So it tends to be about an 8-week course of folate replacement. Anemia of chronic disease is another common one. Obviously, chronic disease is pretty vague, but there's kind of general principles by which diseases affect your hemoglobin level. Usually causes a normocytic anemia, and that's down to cytokine reaction reducing red blood cell production and increasing red cell destruction. It's interleukin-6 that's the most important in this. However, it can also, because lots of chronic conditions also lead to an element of chronic blood loss, there can be inflammation that causes sort of low volume microscopic bleeds. You can also get iron deficiency as well, and that's where microcytic anemia comes into that chronic disease picture. It may not be that you've got frank bleeding, but a combination of inflammation and microscopic bleeds. So, for example, an obvious cause would be cancer or IBD. Those are things that would cause an anemia of chronic disease and would potentially come with a microcytic anemia after a period of time. Often a lot of contributing factors, so a lot of contributing diseases can combine in order to mean that you've got an anemia of chronic disease. CKD is another common one, and with CKD, it's the problem with erythropoietin release. So as part of your production of red blood cells, the hormone erythropoietin is very important. In adults, that is produced in the kidney. It's in your fibroblasts in the kidney. In chronic kidney disease, you get damage to the kidneys. It means that you can't release enough EPO. That results in a reduced production of red blood cells. You also get chronic blood loss and you get chronic inflammation. You can get a nutritional deficiency because people are told to eat less protein in order to avoid damaging their kidneys further. If you're eating less protein, like your meats, your animal products, that's reducing your intake of iron, B12 or folate. So there's a lot of factors going on with the kind of anemia you see in chronic kidney disease, but the headline with that is this reduction in EPO production. And that's the kind of typical one that you see in these patients. Other chronic systemic diseases, so I'm not going to really touch on these today, but these are all things that can cause anemia for different reasons. If you've got any specific questions about them later on, I have got some notes jotted down, so if you want to know a little bit more, please do ask me, but we've got a lot to get through and I want to carry on. Genetic disorders is what I'm going to talk a little bit more about. So, your thalassemias, your sickle cell anemias, hereditary spherocytosis, and G6PD. These are all things that people are born with and inherit from their parents in one way or another. So, these all cause hemolytic anemias. So, we'll talk about thalassemia first. It's autosomal recessive, and what you get is mutant forms of alpha or beta globin chains. So in your hemoglobin molecule, should have 2 alpha, 2 beta chains to make up that complex. In thalassemia, you get malfunctioning forms of those complexes, and it leads to poor function of your hemoglobin molecule. That leads to problems with generating functional red blood cells. The severity of disease can vary massively. It can be, people can be asymptomatic with it and essentially live a normal life. They can have a really severe phenotype where they start pumping out red blood cells from any bone. So normally it's your long bones where your marrow is most productive. If people have got really severe thalassemia, it may be that they start, their body, in order to compensate, starts trying to produce red blood cells from bones like their maxilla and their frontal bones. So you start getting bossing of the front, you start getting swelling in the cheeks, and you get deformity of bones with severe thalassemia. Most people don't have a form that severe. They don't tend to need transfusions. They don't tend to get splenomegaly unless it's severe. Splenectomy can help improve the survival of red blood cells, and in those severe patients reduce the turnover that produces these facial deformities. Sickle cell anemia is also hemolytic anemia, also autosomal recessive, and it's down to just a single gene defect in your beta chains. You get rigid cells that are crescent shaped, and they are prone to causing vaso-occlusive episodes. So people get these vaso-occlusive crises, people get really painful limbs or tummies, and they can be really serious. Sickle cell is a really big topic and affects hundreds of millions of people worldwide. We're not going to get into it too much today because it's a topic in and of itself. Hereditary spherocytosis is another inherited condition, autosomal dominant this time. You get a defective protein in the red blood cell membrane that gives you spherical red blood cells rather than having your nice biconcave structure. You get spherical red blood cells that are quite fragile. So your body likes to clean these out of the system. Where it does that is in the spleen mostly. So you get extravascular hemolysis, i.e. so not in the circulation, but in an organ. Spleen tends to mop up these fragile red blood cells that the body identifies as not really functional. So these patients present with really big spleens. They can occasionally have episodes like acute episodes of jaundice because of their hemolysis, and that tends to go with infection. So if they've got lower respiratory tract infection, as is quite common in kids, that might cause frank jaundice to appear, and you'll note on feeling their tummy they'll tend to have a big spleen. And I'll show you some spherocytes in a second to explain what I mean. G6PD is X-linked, so it means that only boys present with the disease, and it's also really common worldwide. It's down, the people present with acute episodes of jaundice. Infection can trigger those, but anything that causes oxidative stress. So the enzyme G6PD causes the reduction of glutathione. So it's a reduction reaction of glutathione. That glutathione is used to mop up oxidative ions. So anything that causes oxidative stress, glutathione would normally protect you against. G6PD, if you don't have it, you're not producing the glutathione that protects you from oxidative stress. So when you're deficient in that, your red blood cells are a lot more susceptible to any cause of oxidative stress. And that can be, it's classically fava beans, which is the alternative name for G6PD deficiency. The old name is favism. Aspirin, anti-malarial medication, nitrofurantoin, and as I said, febrile illness, any sort of infection can trigger these episodes. And this causes intravascular hemolysis. And there are differences. These two can often be confused. And we'll talk about what we can do to differentiate the two in a little bit when we talk about blood films. Immune reactions. So these are all intravascular causes of anemia. And I will not really tell you too much about them, if I'm honest. The autoimmune ones, we'll talk a little bit more when it comes to talking about investigations, but essentially antibodies attack your red blood cells and destroy them in the circulation. And with alloimmune, it's down to an intrinsic immune response to somebody else's antigens. So your body detects that somebody else's blood has been introduced to your system, and your body naturally tries to defend itself. As a result, lysing these cells often comes from ABO incompatibility. That's the most common one. Bone marrow disorders. So again, there are lots of these. Multiple myeloma is an important one. It's a cancer of plasma cells. It produces abnormal plasma cells that then go on to produce abnormal paraproteins. So your IgGs, and IgG is the most common protein that it produces, but it does produce others. These cells go on to create problems in certain organs. So what you tend to get is the CRAB acronym describes the problems that come with multiple myeloma. So you tend to get a hypercalcemia because you get lytic lesions in the bone. You get renal dysfunction because those proteins build up in the kidneys and damage them. You get an anemia because of bone marrow infiltration. And you get bone pain again because of that infiltration. So the presentation of multiple myeloma can be remembered with CRAB, hypercalcemia, renal dysfunction, anemia, bone pain. And you can treat it with steroids, with chemo, with targeted therapies. Bisphosphonates can help reduce hypercalcemia. The tests for it are two quite specific ones that you just need to remember. So you can test for protein electrophoresis. So you take a serum sample and watch and draw out, so these abnormal antibodies, the IgG that's secreted, you draw them out by electrophoresis and you will get a characteristic marking compared to normal proteins, and that's diagnostic. You can also do urine Bence-Jones protein, which is another test to order. Again, I won't talk too much about the specifics of it, but remember urine Bence-Jones protein and serum protein electrophoresis as your two tests for myeloma. Myelodysplasia is uncontrolled proliferation of stem cells in the marrow. It compromises the production of normal cells. Leukemia is the same with specific progenitor cells. So you've got your acute lymphocytic leukemias, your acute myeloid leukemias, your chronic myeloid leukemias. They're again controlled by uncontrolled proliferation of abnormal progenitor cells. They affect cells at different stages, but they cause anemia by compromising the production of normal red blood cells. You can get bone marrow infiltration with any kind of cancer, really. The most common ones that infiltrate the bone marrow are breast, prostate, and lung cancer. Aplastic anemia is a kind of anemia that is as a result of stem cell failure. You get pancytopenia, which can be seen with some kinds of leukemia as well. But pancytopenia means that you get a low red blood cell count, low platelets, low white cells. So think about what effects that will have. If you've got low red blood cells, you get the symptoms of anemia, as we talked about, fatigue, breathlessness, chest pain in serious cases. Low platelets, bruising, bleeding, and low white cells prone to infection. So if anybody's presenting with that kind of syndrome, you need to worry about them. Do a full blood count, but it may be that they need bone marrow biopsy as well. And pure red cell aplasia is typically caused by an infection from parvovirus B19. For whatever it targets, the erythroid progenitor lineage, and it means that red blood cells just aren't produced, and you get the effects of anemia, but you don't have those effects of infection or bleeding or bruising that you would see with an aplastic anemia. Toxin exposure, there are loads of different things. Just be aware that all of these things can lead to anemia. If you want to look up the drugs, there are plenty of them that can cause anemia for different reasons. I'm not going to list them all now because there's far too many to go through. Macroangiopathic Haemolytic Anemias, MAHAs. So again, there are lots of different ones here. I'm not going to spend too much time on them, but the general principle with these is damage to the endothelium leads to fibrin deposition. So basically, you've got damage to the lining of the vessel. Your body starts to try repairing it. It starts laying down fibrin, but that introduces shear stress to the inside of the vessel. And as your red blood cells run through, they get torn apart by the shear stress, which leads to hemolysis. So you get hemolytic anemia. You also get coagulopathy because as you're laying down fibrin, you're using up platelets and you're using up clotting factors in order to try and repair this damage. These tend to make people quite unwell. And the most serious form of microangiopathic hemolytic anemias is disseminated intravascular coagulation. People get really, really sick with this. So if you've got somebody who is bleeding and has so they tend to bleed even though it's pro-coagulopathic. You're clotting in little vessels and it's not stopping bleeding. So people will tend to present with purpura, with bruising, with evidence of hemorrhage as well. In terms of your exams, what you need to do is make sure that if you see something like this, this would be a case of calling for help in the NOSCI situation. I don't think they would give it to you, but people will tend to be very unwell with DIC, and it's something that can result from any of these situations. And blood loss, finally. So we're going to talk about, so with acute hemorrhage, it causes normocytic anemia initially. After about 6 hours, you start getting a reactive reticulocytosis, which means that you get more big cells being pumped out. Chronic blood loss, you will lose your iron stores because you have, as I said, 2/3 of your body's iron stored in the circulation. So with chronic blood loss, you will tend to get microcytic anemia. Right, your investigation stored. Does anybody have any questions about any of that? Want to know anything more about any of those things that I've just mentioned? Okay, so your key investigations for anemia is obviously a full blood count. B12 and folate are really important if you've got a microcytic anemia. Iron studies are really important as well if you've got a microcytic anemia because they can help you quickly identify an iron deficiency, although, as I'm going to go on to mention, there are lots of reasons why it may not be accurate. And a blood film is really helpful as well. Endoscopy and bone marrow biopsy might come later on, depending on what you identify and what the patient's exact clinical circumstances are. So this is a quick look again at a full blood count. We're going to have a look at, so if this comes back as low, we want to have a look at ordering some iron studies in order to help us identify whether or not it might be iron deficiency anemia. So these are the categories that you get from iron studies. Let me tell you a little bit more about them. So serum ferritin, as I mentioned, is the best way to tell if somebody's iron deficient. Most of your ferritin is stored intracellularly, but you get a small amount in your serum. It is the one that most closely correlates to your body's iron stores. If you see a low level of serum ferritin, you've confirmed a diagnosis of iron deficiency. If it's high, that may be down to a inflammatory reaction, so it doesn't necessarily rule it out, but a low ferritin does confirm iron deficiency anemia. These tend to be the patterns that you will see with serum iron. The problem with serum iron is that it varies wildly. It varies with your diet, it varies with inflammation, it varies with infection. So serum iron is not particularly helpful with determining what is going on with an anemia that you might see. Total iron binding capacity is equivalent to a transferrin as well. Transferrin is the transport protein that takes iron into your cells, into your red blood cells. So transferrin increases when you're iron deficient, and that is in order to maximize the use of any available iron that you've got. So if you're iron deficient, your body's going to try and take up all the iron that it can get its hands on and make more transferrin and increase its total iron binding capacity. So if you're iron deficient, you're going to increase your transferrin to try and take advantage of any iron that you have in your system and increase your total iron binding capacity. Because you're making more transferrin and there's not much iron kicking around in your system, because you're increasing this number's going to go down. Your transferrin saturation is going to be less. But this is, again, also got problems with its accuracy. So serum ferritin is basically, for the purpose of exams, serum ferritin is the stuff that's going to be most indicative for you. Look at your HB, look at your MCV, look at your serum ferritin, and that should tell you enough to go on, along with the clinical stem that you've got in any questions. So we're looking at a blood film. So this is a normal blood film, and these are nice, healthy erythrocytes. They're round. They've got that biconcave structure. That means we've got a little bit of a paler center. These are some of the different types of white blood cell that you get in your system. So lymphocyte is in your lymphoid progenitor family, and your neutrophils, your eosinophils, your basophils, your monocytes are all myeloid progenitors as well. So this would be a normal blood film. If we move on to this blood film, this identifies some of the features of iron deficiency anemia. So that target-shaped cell, you've got a little bit of darkening again in the center. Hyperchromic, they look a little bit paler as well. The pencil shape, this is also known as a poikilocyte. And they're microcytic. If you measure the size, these are smaller than these red blood cells. So this just highlights some of the features that might be mentioned in text of a question, or you might be shown a film. There wouldn't be many questions, if any, on actually looking at a blood film, but it might be a clue. They might give you a stem that suggests one thing, and this might be added evidence towards helping you make your mind up as to what's going on. So this is a typical film. All of these features fit with iron deficiency anemia. This is a blood film for megaloblastic anemia. So megaloblasts are bigger red blood cells. These, if you measure them, are bigger than normal erythrocytes. We don't have them to compare here, but these are bigger than your average red blood cell. The giveaway, though, is actually not the megaloblast, but the hypersegmented neutrophil. So if you look here at a mature neutrophil, we've got probably 1, 2, 3 portions to the nucleus of this cell. Whereas if you look here, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. There's loads of little portions of the nucleus of this cell, and the cutoff is more than 6, counts as hypersegmented. So if you're seeing big red blood cells with a hypersegmented neutrophil like this, that's your giveaway for megaloblastic anemia. And that, seeing this written or seeing this image is going to give you a giveaway for B12 or folate deficiency. These are schistocytes, which are the fragments of red blood cells that are produced by intravascular hemolysis. So if you've got a microangiopathic haemolytic anemia, or you've got thalassemia, or you've got G6PD deficiency, all causes of intravascular hemolysis, these are the resulting fragments of red blood cells. That shear stress that we mentioned causes the red blood cells to rip apart, and you get these irregular shapes that are characteristic of intravascular hemolysis. These are spherocytes, and you notice that they haven't got that nice little light patch in the middle. And these are what you would see in spherocytosis. All of your cells look like this. In any form of hemolysis, these will be there. But in hereditary spherocytosis, all of your cells will be spherocytes. So they're not specific, but if you've got all spherocytes, it gives you a clue as to what's going on. So the reason that I've got the Coombs test next is because the spherocytes are also common too. So you can also see, you get spherocytosis in microangiopathic haemolytic anemias. Sorry, in autoimmune, not microangiopathic, in autoimmune haemolytic anemias. So spherocytes are also common to autoimmune haemolytic anemias. So like you would see in SLE or in rheumatoid arthritis. So the way that you tell apart, if you see a film that has all spherocytes, the way that you can tell them apart is you do a direct Coombs test, which is checking for antibodies. And what you would do is take your sample, you wash away everything that isn't red blood cells, because in hereditary spherocytosis, there won't be any antibody bound to those red cells. In your autoimmune hemolytic anemias, like in SLE, they will have antibody bound to the surface. So then, with these red blood cells that either do or don't have antibody on the outside, you add Coombs reagent. And if you've got antibody stuck on the outside of your red blood cells, the Coombs reagent binds them up, and your sample of red cells bunches up, and you get left with these agglutinated red cells. So this is a positive test result. If you saw this in somebody that had spherocytosis, this would suggest that it's an autoimmune reason for that spherocytosis, rather than hereditary spherocytosis, which is a negative test result with Coombs test. So, talked about a few big causes of anemia. We talked about how you can identify an iron deficiency anemia using a full blood count and an MCV, and iron studies, and a blood film. We've talked about how the MCV can point you towards a B12 or folate deficiency, and how a blood film clinches that diagnosis. We've talked about how hemolysis presents, so you tend to get a normocytic anemia. Loads of different things cause hemolytic anemias. So we've talked about some of their common features on blood film, but also some of the things that set them apart. So whether it's intravascular or extravascular hemolysis, and whether Coombs test is positive, because this will confirm for you an autoimmune reason. So covered quite a lot in a short space of time. I'm now going to go on to some MCQs just to talk about some key topics a little bit more. I'll try not to spend more than half an hour on these. So if you guys go to kahoot.it on your device, we will go through some questions quite quickly. So if you enter that pin, go to kahoot.it, game pin 1395921, So 1395921. We've got 7 questions to go through, which gives me I've just realised actually that my chat wasn't popping up earlier on when I was asking you about the signs. Thought I was responding to deathly silence, but my chat has now just popped up and you have given me the right answers for all of them. So I apologise for lingering on each of those a little bit too long. Right, so we've got how many people in this chat? 1, 2, 3. Still waiting on a few more to join in. 1395921. So if you go to Alice, if you go to kahoot.it, put that pin in again, and we will do some questions quickly. The rest of the 3 of you are going to join in? Okay, having some problems. I'll put that in the chat box. And we will we'll just make a start with questions. So we're going to go backwards and forwards a little bit between these 2. The questions will be on here and then we'll answer them on Kahoot. So 17-year-old woman has been admitted following a distal tibial fracture. Routine pre-op blood tests are performed. What is the most likely cause of her full blood count abnormality? So for you guys that haven't managed to get on to Kahoot, just have a think in your head about what the answer might be to this question. Take a look at the hemoglobin, take a look at the MCV, and that should guide you towards broad categories of anemia. And hopefully from that, from what we talked about earlier on, it might give you a bit of an idea of what's causing this. And then we'll go through. Once we show the answers, I'll tell you a little bit more about why it's the right answer. Okay, so move on to seeing the answer. So, what was the most likely cause of her full blood count abnormality? Okay, so beta thalassemia, and I'm going to tell you why. So, we'll have a look at the answers here. So, first of all, let's have a look at all of the answers we've got here. Acute lymphoblastic leukemia, beta thalassemia trait, iron deficiency anemia, polycythemia vera. So, polycythemia vera is not something I've mentioned at all today, but that poly means lots of. So, polycythemia vera is a condition that causes a raised hemoglobin. So, if you know what that is, you can immediately rule it out and say that this is not the answer to this question. This lady is a little bit anemic and she's got a very, very low MCV. With acute lymphoblastic leukemia, you might have an anemia, But what you would also expect is a raised white cell count. And if we looked at the breakdown of the white cells, we'd identify that there'd be a lot more lymphocytes. But what we would be expecting with ALL is there'd be a raised white cell count, a raised lymphocyte count. And with acute lymphoblastic leukemia, we would expect there to be lots of blast cells, so lots of premature cells. Then it comes down to beta thalassemia trait or iron deficiency anemia. And this comes down to knowing a little bit about how they tend to present and how the MCV is related to the anemia. So iron deficiency anemia tends to, it could well be the case in a 17-year-old woman, but with an MCV that low, you would think that she would be more anemic than that. That really small MCV, so 65 is a way off 80 in terms of that value, but she's really not that anemic. Like, she's managing pretty well, and that's pretty classic for thalassemia. So what this lady's got is a mild form of thalassemia. So she's got one aberrant chain that's resulted in an MCV that's quite small, but her HB is pretty good. And if you see that, so the classic thing with thalassemia trait is an MCV that is disproportionately low for the hemoglobin count. And that's basically the clincher for this question. So that's the teaching point that I'm trying to get across here. This is a lady who she's not been symptomatic. We can see from the stem, this has been picked up incidentally and it's not bothered her before. So this MCV out of proportion with the degree of symptoms and the degree of anemia is classic for beta thalassemia. Right, next question. Let's just quickly click this on. Okay, good. Right, so our next question. 36-year-old man presents to his GP complaining of feeling slightly fatigued. He has no past medical history. He doesn't smoke. He drinks about 10 units a week. 2 years ago, he moved to the UK from Greece, where he was born, and currently works as a builder. On examination, his chest is clear to auscultation. Heart sounds normal. As part of his investigations, a full blood count is done. Given the most likely diagnosis, to explain this full blood count, what other investigation finding would be consistent? So, things to note here. He's symptomatic, isn't he? He's never been diagnosed with anything before. He's from Greece, and he's got a normal examination. He's got a low HB, he's got a low MCV, he's got a very low MCV, normal platelets, normal white cell count. So, which of these features would you see on which investigation finding would you have? So, think about, you don't necessarily need to know the right answer. Try and use a little bit of exam technique to try and help you work out what it might be. Is there anything that you can rule out based on what these investigation findings are and what the STEM says? Is there anything here that it definitely won't be? And if you cross those off, even if you don't know the answer, you give yourself a better chance of guessing what the right answer is. So think about each of them in turn. Think if you can rule it out based on what you've been told, and give yourself a better chance of answering it correctly. Right, I'm going to tab over to the next question then. Okay, good. So we'll talk about that in just a second. So the reason that it is a raised HbA2 level. So this guy's diagnosis, does anybody want to tell me what he's got? Thalassemia, yeah, absolutely right. So was checking if you were paying attention to what I was saying in the last question as well. So he's got an MCV that is really small compared to the degree of anemia that he's got, which, as we've said, is thalassemia. That doesn't tell you exactly what the answer is, though, to these questions. If you've been paying very close attention to what I was saying earlier on, I briefly mentioned that thalassemia can cause problems with alpha or beta chains, depending on which type you've got. So what happens is, if you've got a problem with your beta chain production, you will then start pumping out different kinds of hemoglobin. Your body's able of making different kinds of hemoglobin. So if you can't make beta chains, you will make alpha-2 chains, a different type of alpha chain, in order to make these complexes and still try and bind oxygen, make sure that your tissues get the oxygenation that it needs. If you know that, you'll get this answer right straight away. So you know thalassemia, and then you can go to, right, okay, so your body's going to make some different hemoglobin chains in order to compensate. But you don't need to know it, because we can try and rule some of these things out. So megaloblasts, what are they seen in? Megaloblasts are big red blood cells, means that we'd have a raised MCV. It's not going to be that, because the MCV in this case is low. So it's not going to be because megaloblastic anemia would produce a raised MCV. Positive Coombs test is found in autoimmune hemolytic anemias. That's what I said earlier. So autoimmune hemolysis doesn't change the MCV at all. So what you would get is a normal MCV with a positive direct Coombs test. And then your raised ferritin level would be with infection or inflammation, or if they've got a high level of iron. Basically, this wouldn't be particularly informative for this diagnosis. If this said low ferritin level, and you've got a low MCV and HB, it might be a little bit harder to get at. But it says raised. It basically leaves you with a raised HbA2 level, even if you don't know the reason for it, as being the only possible option that you could get. So that's the reason why you could get to that, even not knowing that thalassemia results in increased production of HbA2. Right, let's move on to my next question. So, a 68-year-old man presents to the emergency department with a 3-hour history of sudden onset breathlessness. He's a regular smoker, he has a 40-pack year history, he has a past medical history of angina and sickle cell disease. His observations are all in the normal range. He has conjunctival pallor, and you notice that he's got hyperresonance and reduced breath sounds over the apex of the left lung. An ECG and serial troponins are normal. You're concerned about whether this man needs a red cell transfusion. So according to NICE guidelines, what hemoglobin threshold would prompt a transfusion for this man? So if you saw that his HB was less than one of these answers, what would, which of these levels would prompt you to transfuse him? So he's got sudden onset breathlessness, he's got a history of angina and sickle cell disease, his observations are okay, he's got pallor, hyperresonance and reduced breath sounds at the left apex, his ECG and his TROPs are normal. What's your target? What level would make you transfuse this man? Okay, so it's 70, and I'll explain why. This is just it's a pure knowledge one. So when somebody's hemoglobin is less than 70, you give them a transfusion. If it's higher than 70, you would give an iron infusion if they were symptomatic and in hospital. If they were stable and in the community and it was a bit higher than that, you might give them iron replacement therapy with tablets. That 80 that a few of you have put does also exist as a cutoff for transfusion, but it's only in the context of ACS. So if somebody is having an MI and they've got an HB of 75, you would give them a transfusion. However, this guy has got a normal ECG and normal troponins. He's not having chest pain. So these investigations mean that he doesn't meet that criteria for a transfusion yet. So let's say his HB is 75, this man wouldn't get a transfusion. If his HB was 65, he would do, because that 70 is the cutoff in somebody that's not experiencing an acute coronary syndrome. So that is it's a pure knowledge question, this one. Because of this man's presenting complaint, because of how he's presenting, he would be transfused if his HB was less than 70. And if he was having an acute coronary syndrome, it would be if his HB was less than 80. Okay. Right, next question. 21-year-old man attends the emergency department. He's been feeling fatigued, generally unwell for the last 2 days. He's been getting out of breath quite easily. He's normally fit and well. He's not on any regular medications, but he has recently started taking Primaquine in preparation for a trip to Tanzania next week. He is clearly jaundiced and he's short of breath. He doesn't have a temperature. His blood pressure is okay. He needs a little bit of extra oxygen to maintain his stats. His results show that he's got anemia, he's got normal MCV, normal platelets, normal white cells, slightly increased reticulocytes, and on his blood film, we've got schistocytes, spherocytes, and bite cells. So I have to remember back to a little bit of my discussion earlier on. What do you think is the most likely reason for this man's presentation? But again, after you answer this one, I'll just talk through why the answer is what it is. Okay, so move on to answering this one. Good, well done. So it's a tricky question, but there are a few things that give it away. So he's 21 years old. He's jaundiced. He's short of breath. He's recently started taking Primaquine. So that's going to be quite an important factor in deciding why this guy is presenting as he is. He's got a Normocytic Anaemia. He doesn't have evidence of an infection. And his blood film shows spherocytes, schistocytes, and bite cells. So I haven't talked about bite cells so far today, and I'm not going to cover them now. But as we said earlier on, spherocytes are generic cells in haemolytic anemia. They show up in all different kinds. In hereditary spherocytosis, that's all you'd see. You wouldn't see these other cells as well. Schistocytes are those fragments that you get in intravascular hemolysis. This is a condition that is categorized by extravascular hemolysis, i.e. in the spleen. You get a big spleen with hereditary spherocytosis. Post-infectious hemolytic anemia, we wouldn't be expecting it because we don't think he's got an infection. He has a normal white cell count. He has normal platelets. The platelets are an acute phase protein as well. They might be a little bit more elevated than that in an infection. Sickle cell crisis, well, he doesn't have anything that makes me think that he's having a sickle cell crisis at the moment. The G6PD deficiency, he's a young man, so he's male, so it could definitely fit with G6PD. He's got a normocytic anemia. He's got fragments of cells. Doesn't mention any sickle cells on this blood film as well, does it? So he's got evidence of intravascular hemolysis, and he's got one of the medications that is typical for causing oxidative stress. So all of that in combination points to G6PD being the reason for this man's reason for his presentation with jaundice and anemia. And often it'll take something like that, as again with G6PD, people will often be very well in between acute episodes, and they can go undetected. They may not have a presentation before starting taking a medication like that. So, good. Right, we've got 3 questions left to go, and then we're done. A 54-year-old man presents to his GP with a 1-month history of fever, malaise, and weight loss. He also complains of abdominal fullness and early satiety. His past medical history and travel history is unremarkable. He is not on any regular medications. On examination, the GP detects splenomegaly. The results of his full blood count and white cell differential are presented below. What is the most likely diagnosis? So the question on leukemia. I'm going to tell you a little bit about how to work this out in just a second, but have a look, see if you can figure out which one it is. Have a think about those progenitor cells. Think about the lineages that they come from. So lymphocytes come from one particular lineage, and your red blood cells, the rest of your white cells come from a different type of lineage. So think about what that might represent in terms of where this what the diagnosis is in this case. It's a difficult question, this. I was always struggled with leukemia when I was at medical school, but I'm gonna tell you a way to try and identify what is going on. So we'll tab over to the question. Okay, so it's a difficult question, this. So I'm going to tell you why it's CML and not any of the others. So with acute myeloid leukemia, blasts are a big feature. So it's an acute cancer. So what you get is lots of immature cells. It's something you get a sudden presentation, but it's because you get lots of young cells being produced. So in that, let me tab back up to this, you get lots of blast cells, so lots of progenitors being produced. Lots of these being produced. In chronic myeloid leukemia, you get cells of lots of different stages of maturation, also known as bands. So it can be referred to as bands or stages of all stages of granulocyte maturation is how they might be referred to in questions. Blasts are key to AML. So you'll get young immature cells and it will say you'll have a percentage that is blasts and it will be high. ALL and CLL, we've got a low lymphocyte count. So it won't be either of those two. The reason is chronic myeloid leukemia. So we've got a high, look at this white cell count, which is really, really high. Also, I'll mention as well, so this is too high really to be an acute myeloid leukemia. A white cell count that high, you wouldn't see it with an acute leukemia. So splenomegaly is also not seen in acute myeloid leukemia because of this build-up of aberrant cells. They are taken out, they're removed by the spleen. So as they build up, you get splenomegaly in this case. So the way to go through leukemia is look at the lymphocyte count, first of all. Is it high or is it low? If it's low, it's not going to be lymphocytic leukemia, either acute or chronic. So look at the lymphocyte count first. If it's low, it's going to be a myeloid leukemia. Then look at the white cell count. If it's this high, if it's 50, 80, 100, that points you more in the direction of chronic myeloid leukemia. And then look for hints from the other cells that are in the stem or in the actual data that you've got to interpret. So something in the stem that says all stages of granulocyte maturation are present, that would be chronic leukemia. Something that points to bands being the predominant form of myeloid cell, that would also be a chronic leukemia. Something that points towards blasts or immature cells is an acute leukemia. And with chronic myeloid leukemia, you also get splenomegaly. This acute history, so 1 month history, actually isn't significant. So you can't put too much weight on the amount of time they present over, because often these people will have a lack of symptoms. This will be indolent for a long time and people won't present with it. They'll notice changes quite suddenly, but that doesn't have any bearing on the type of cancer that they have. So although this presentation's over 1 month, that doesn't mean that it's an acute leukemia. Also the age group for this man. So ALL is something that you get, it's a childhood cancer. AML tends to be 60 plus, CML tends to be kind of 50 plus. Not hard and fast rules, but he leans more towards the age bracket that CML presents in as well. So there's a few different things that point towards this being chronic myeloid leukemia. It's a difficult subject to get it down, but hopefully now it's given you a system to go through. So looking at the lymphocytes first, if they're low, you know it's not going to be a lymphocytic leukemia. Then looking at the white cell count. White cell count this high doesn't happen overnight. This is something that grows and grows and grows over a prolonged period of time, and it points towards more a chronic picture. And then look for other clues from the stem or from the cell breakdown that you've got, looking for bands or mature cells pointing towards chronic, and blast cells are the key thing to look for in an acute leukemia. Okay. Does that all make sense, guys? Please just shout up if you want to know any more. 2 questions ago. So 63-year-old man presents to his GP with 3-month history of feeling tired all the time and getting out of breath when walking. He has felt low in mood and he has less interest in his hobbies. He hasn't weighed himself, but he has noticed that his clothes are hanging looser. GP has arranged some blood tests which show the following. Which investigation is most useful in investigating the underlying cause of his symptoms? So have a look through the blood tests, try and pick out what they're showing you. We've seen that there's a low HB, so jump to the MCV and see what that tells you, see if that points you towards a diagnosis or not. And have a look at what some of the other things are looking for. And just as a clue, obviously, you've seen a lot of full blood counts in this, this question so far. The fact that this question includes renal function and calcium is something that you should potentially read into, because you can see that some of those values are abnormal. So try and think about what that might be pointing towards. And again, look at what the question is exactly asking you here. A lot of these investigations might be pertinent things to do, but what the question is asking is what's going to be the most useful in identifying the underlying cause. So although we might do a lot of these, there's one answer that is better than the others because it's going to identify the underlying cause of his symptoms. So make sure that you're answering the question being asked of you when it comes to your MCQ papers, rather than what question you think they might be getting at. Always answer the one that's on the paper. So you've had a chance to look at the blood results, think about the stem, and think about what's going to identify the underlying cause. I'm just going to go over to the question. Okay, serum electrophoresis, good. So the reason that it's serum electrophoresis is because this man has got hypercalcemia, he's got renal impairment, he's got anemia, and although he doesn't have bone pain at the moment, he has been losing weight. So this guy has got a lot of the presenting symptoms of multiple myeloma. If you can get that, the hypercalcemia and the renal dysfunction and the anemia is pointing towards multiple myeloma. So this depression as well, hypercalcemia often can cause depressive symptoms. So all of these things, and these obviously these are symptoms, the tired all the time is symptomatic of anemia. Trying to work out which of these is going to be the best. So you need to identify from the blood results that it's hinting at multiple myeloma. And then what is the thing that's going to pick up that diagnosis? So a CT tap will be helpful for looking for possible metastases for cancer. In multiple myeloma, actually a bone scan is the best thing to do to look for distant mets, because it's cancer of the plasma cell lineage. You tend to get these bony lesions, and the best way to look for them is with a radioisotope bone scan. A PSA is not really hinting at prostate cancer because it hasn't mentioned urinary symptoms, it hasn't mentioned lower back pain, hasn't mentioned the urological history. So although he's 63, is not really getting it enough here for you to, and a PSA also is not a very specific test, so you'd never use it to diagnose a prostate cancer. Serum electrophoresis, or if that's said urinary Bence-Jones protein, is getting at an underlying diagnosis of multiple myeloma. So although some of these would be appropriate, and certainly a radioisotope bone scan would be used in the workup of a man like this, this wouldn't actually tell you specifically what the diagnosis is, whereas this does, this doesn't, this doesn't, and this doesn't. These aren't diagnostic tests. This is a diagnostic test. In the same way that if he had a lung cancer, a CT tap wouldn't tell you definitively what type of cancer that is. It wouldn't tell you your small cell from your from your adenocarcinoma, but it would help with the workup. This is diagnostic, these ones aren't. So we'll move on to my last question. 45-year-old man complains of feeling tired all the time to his GP. He has no other symptoms and his examination is normal. Blood tests are arranged which show the following. Based on the above findings, what is the next most appropriate step? So have a look at the HB, have a look at the MCV. We've got some iron studies there, which may or may not be helpful. What are we going to do based on that? Oh, I'll tell you what, actually. I shouldn't say 1, 2, 3. I do apologise. Have a think about that, but what that says. I think I copied that from the previous slide and forgot to change it. That is what his blood results should be. So 45 years old, tired all the time, no other symptoms, HB of 103. And that should be that either. No, I have just copied that over from the last one. Or from a previous one. I do apologise for this, guys. Yeah, I copied that over from the leukemia one, actually. That's where the white cells are 102. That can be, let's just say 7.5. Fine. Sorry about that. Yeah, so he's got HB of 103, MCV of 75, normal platelets, normal white cell count. I do apologise. Ferritin low, iron low, total iron binding capacity high. So based on these numbers, along with this extra information, these presenting complaints, what is your next most appropriate step? So I will tab over to the question. Two-way wet endoscopy, good. Okay. Nice work, well done, eh? So, the reason that with the correct blood results, that a 2-week wait is the right answer, as I mentioned earlier on, so anybody over 60 with an iron deficiency anemia should be referred for upper and lower GI endoscopy as a 2-week wait, and also in a man of any age that has an iron deficiency anemia and an HB of less than 110, because of the possibility of a GI cancer. So this man has an HB of less than 110. That is a nice guideline. You can see from his MCV that it suggests that it may be iron deficiency, and when we look at the ferritin, that's low as well. So we've confirmed an iron deficiency anemia with an HB of less than 110. So that defaults to an upper and lower GI endoscopy under the 2-week wait pathway. If his HB was 123, then it might be appropriate to do further bloods, including TFTs or bone profile or hemoglobinopathy screen. It might be appropriate to investigate him for celiac disease if he started having GI symptoms. Referring for a CT tap, although you're appreciating the urgency of the situation, it's not going to necessarily yield the information that we want. We need to visualize the bowel in order to look for a GI cause, which is the most urgent thing to rule out. If that was normal, then we can think about doing some more of these. We might do them on the same day, actually, but we certainly wouldn't do this without doing this. So that is why D is the right answer for the final question. So these are the references that I have used. Do you guys have any questions at all? If so, please do ask me. I have put a form in the chat as well for just a little bit of feedback, just to help me make things a bit better for next time as well. So please click on that link, give me a little bit of feedback on what you thought was good, what you thought could be better. It's a huge topic. I know that it's a little bit scattergun today. So please let me know what you thought was good, what you thought I could improve on for next time. And I will see you guys again probably at some point in the next round of 6 weeks after my colleagues have taken a turn presenting to you. But thank you very much for listening to me today. All right.
Thank you.
Thank you very much. We'll see you next time.